Good evening, everyone. Welcome to Everyone Counts webinar series on wealth and health equities, a conversation with Dr. Noel Braithwaite, Dr. Letitia Duraza, Dr. LaQuandra Nesbitt, Dr. Shauna Intieri, and Mr. Earl Stoner. We're glad that you're here with us tonight. I'm your host, Reverend Dr. Stacy Cole Wilson, the Executive Minister of Justice and Service for the Baltimore-Washington Conference of the United Methodist Church. We're glad that you are with us, whether you are joining with us live tonight or via YouTube or any of our other social media platforms. Welcome. We invite you to go to www.bwcumc.org to check out our YouTube channel and to also find out the other ways that you can offer your voice in this present age with us. Please feel free to orient yourself to this virtual space. We have the question and answer section that we invite you to offer your questions throughout the presentation. We also invite you to talk within the chat. If there are resources that you have that you would also like to share with us, we invite you to do so. And if you would like to communicate with us throughout this time together, we'd also invite you to do that. At this time, I want to introduce the panelists, the two co-moderators with me today, Reverend Dana Jones, who is the chairperson of our Wealth Equity Justice team, and Reverend Rochelle Andrews. At this time, I'm going to invite Reverend Jones to lead us in prayer.
Let us pray. Holy One, we thank you for this time in which you have provided us with the grace of those who you have provided wisdom to, that they might impart such to us, that your holy church may be able to work in partnership with community, that we may work towards the wellness for all citizens. We ask for the grace of listening and the power to discern your will as we seek ways that your beloved community may seek full wellness. Amen.
Amen. Thank you, Reverend Dana. Again, we give God thanks for our webinar team, Reverend Rochelle, Reverend Dana, and myself. Also give God thanks for those who are gathered here to lead us in this presentation. Dr. Noel Braithwaite, welcome. Joined the Office of Minority Health and Health Disparities on December 6, 2017 as director. He is an international public health expert who gained experiences working with health issues in the United States, the Caribbean, and parts of West and East Africa. Prior to joining MHHD, he organized the Greater Los Angeles Health Network to collaboratively tackle urban and suburban issues of health that continue to disproportionately impact people of African descent. Some of his other past experiences include leadership positions with Florida Department of Health, the University of Miami School of Medicine Cancer Center, Morehouse School of Medicine International and Public Health Program, and as Director of Research in Trinidad. His vision is to work collaboratively with the MHHD team and other stakeholders to position the MHHD as a transformative and innovative agent that significantly lowers health disparities within the next decade. His goal is to advance prevention, equal health care access, quality treatment, and improved health for all populations in Maryland. Will you help me welcome him? Thank you. Dr. Letitia Duraza joined Baltimore City government as the Commissioner of Health in March 2019. Dr. Duraza, a Hopkins-trained pediatrician, believes that equitable care is a basic right for all and will tirelessly advocate for programs that support the overall health and well-being of all Baltimore City residents. Dr. Duraza's special interests include obesity management and prevention, trauma-informed care in children and adolescents, and expanded use of technology to improve health outcomes. Prior to joining the health department, Dr. Duraza worked at Fearless Solutions, a Baltimore-based digital services firm that builds custom software solutions for local and federal government clients. She holds a BS from University of Maryland, Baltimore County in Biological Sciences. She graduated from Meharry Medical College, summa cum laude, in 2007. She lives in downtown Baltimore with her husband and son. Please help me welcome her. Dr. Letitia Duraza, yes. Dr. Shauna Inchiri. She's assistant professor in the Department of Family and Community Medicine at the University of Maryland School of Medicine. She also serves as the medical director for the Baltimore City Cancer Program and the senior medical advisor for community outreach and engagement at the University of Maryland Greenbaum Comprehensive Cancer Center. She divides her time between direct patient care, teaching, community-based cancer control efforts, and research. Her research interests include health disparities, particularly in relation to cancer screening, and the impact of community and primary care-based cancer screening initiatives upon health outcomes for urban underserved patient populations. Dr. Inchiri is a graduate of the University of Michigan, where she studied English literature, and Boston University, where she obtained a Master of Public Health in Social and Behavioral Sciences. She received her medical degree from the College of Human Medicine at Michigan State University and completed her residency at the University of Maryland's Department of Family and Community Medicine, where she is also served as a chief resident. Welcome, Dr. Shauna. Dr. LaQuandra Nesbitt is a board-certified family physician with over a decade of experience leading population health initiatives and governmental public health agencies. Dr. Nesbitt currently serves as the director of the District of Columbia Department of Health in Washington, D.C., a position she has held since January 2015 when appointed by Mayor Muriel Bowser. As a physician leader, Dr. Nesbitt mobilizes, organizations and communities to implement innovative solutions that promote health and wellness and achieve health equity. Throughout her career, she has led multi-sector collaborations to address innovation in healthcare delivery and its impact on high-cost, high-need, and other special populations. The integration of public health and healthcare, and the impact of medical marijuana and decriminalization of marijuana possession on the public's health. Please help me welcome her. Mr. Earl Stoner is the health officer for Washington County Health Department, and in this capacity, it is his responsibility to determine the public health needs and issues of Washington County, Maryland, to design and implement programs to meet those needs, to enforce the health laws of the state of Maryland and local government, and to direct the Washington County Health Government. We're so honored to have him here tonight, as well as all of our guests. Again, please help me welcome them. At this time, I will invite Dr. Braithwaite to lead us with his presentation.
Good evening, and thank you for this invitation. I accepted gladly. And my conversation is about wealth and health. I think that if we look at poor countries and rich countries and poor counties in Maryland and also rich counties in Maryland, we will see a particular trend occurring. And one asks the question, is there a difference between the health outcomes of rich counties in Maryland and also the poor counties in Maryland? I'm going to look at two counties in Maryland, Prince George's County and Montgomery County, and use those to look at the region, the Mid-Atlantic region, and draw some conclusions that from West Virginia and Maryland and go over to Delaware, Philadelphia, to New York, and try to answer the question, are there substantive differences between the health outcomes of rich counties and poor counties, or rich families and poor families, rich individuals and poor individuals? So the question that comes to mind is, how do we measure wealth? I think that we measure wealth according to a number of definitions by income. And that's one way that we measure wealth. So when we go to the census, we find that there are indicators of rich counties and also poor counties. As a matter of fact, there are 25 rich counties in Maryland, we have the top 25 rich counties in Maryland, and we also have the top 25 poorest counties in Maryland. Sorry, top 25 wealthiest zip codes in Maryland, and we also have the 10 wealthiest counties in Maryland, the 25 poorest zip codes in Maryland, and also considered to be the 10 poorest counties. And so we can look at the adjusted gross income, and they would tell us that the highest gross income per county in Potomac. Montgomery County has some of the richest counties. You have the zip codes, including Potomac, Bethesda, Chevy Chase, and we also have in Baltimore City zip code 21210, which is ranking among the 25 richest zip codes in Maryland. When it comes to the poorest zip codes in Maryland, a number of them are in Baltimore City, 21205, and we have in the Dorchester, also one of the poor zip codes. And then in Prince George's County, we have the zip code 20783, which is considered to be Hyattsville and Bladensburg and Riverdale. And then in Montgomery County, Silver Springs. So we can place on a map the richest counties and the richest zip codes, the poorest counties and the poorest zip codes in the state. And that can be done throughout the Mid-Atlantic region, where we can have those measures of rich and poor. And then the other question is, do we also have a comparison, a link between poverty and health and richness and health? I think that by all measures, studies have shown and supported the intersectionality or the link or the correlation between wealth, as whether we measure wealth like per capita income or family income, and health outcomes, if we measure health outcomes by the disease prevalence and also by death. And so when we look at if we look at now the current disease that is ravaging the entire state and also the entire country, and let's say it's pandemic the world over, if we take that as an example and lay over that wealth and poverty, we find some interesting things taking place. As I mentioned, that the wealthiest zip codes, we do have them, and also the poorest zip codes. And one of the interesting things is that there's not always a fine delineation between the zip code boundaries, and that in some zip codes we have wealth, and the same zip codes we also have poverty. And so when we look at the relationship between those two, we find that in a place, let's say, in Upper Marlborough, where we might have the notion of wealth, when we look at that, the cases of COVID-19 are not as high as when we look at a poor zip code within Prince George's County, like 20783, which is the Hyattsville area. So within counties and between counties, we have disparities. And within zip codes, we also can experience this, that same level of parties, because within some zip codes, we can have some sections that are considered to be rich, and some sections are considered to be poor. But if we look at the differences between counties, let's say the counties that are considered high rates of COVID, we find that within Prince George's County, the zip code 20783. And when we look at the income of 20783, it is different from the income of the zip code that says 20769. So we can see disparities between the zip codes as look at COVID-19. So the situation then is that wealth is an indicator of health, and poverty is also an indicator of health. And sometimes wealth contextually might have some different health outcomes. For example, it is indicated that chronic disease might more be a health disease, a wealth disease, than possibly infectious diseases. So that STDs and HIV and those kinds of infectious disease might more likely be associated with poverty. But we also have now a cross-section whereby both the wealthy and the poor are suffering from prevalence of chronic disease. But it is said that when it comes to chronic disease like hypertension, that the awareness of hypertension and also the control of hypertension might vary by wealth, by your income. So that even though the prevalence might be narrow, the awareness and the control would differ on the basis of income. So that gives me a sort of a setting to indicate that there's enough data to show and to strengthen the fact that there is a correlation, there's intersectionality between wealth and health, and also between poverty and health. And the great example that we have today is that of COVID-19. In that COVID-19, even though we say that COVID-19 knows no boundaries and no geography, the evidence indicates that the poor counties in Maryland, the poor zip codes in Maryland, have higher confirmed cases and also the deaths. So that when we look to do something, we are also asking where are the hotspots? And very often those hotspots are in the poor communities. So when there was a call by the legislators to produce evidence by race and ethnicity of COVID-19, we find that the race and ethnicity indicated that in the poor counties and the poor zip codes, we had a heavier burden of COVID-19. And there was justification for that because we know that intervention follows the discovery of evidence and data. Now, the question is, do we have the evidence that there is this intersectionality? And the question is, if we are driven by some of the explanations, what are some of those? We find that the social determinants of health will be the great explanation of the difference between the health outcomes of the rich counties and the poor counties, in that, and also between rich families and poor families, and rich individuals and poor individuals. And some of the things are lack of access to healthcare facilities is one of the challenges that we can look at. And we also have the lack of health insurance coverage. We have dense and crowded areas and multi-family homes and apartments. And that we have also essential workers to be considered to be more in the low income grouping. And we also have evidence of food deserts. And evidence of food deserts would suggest that they might be more located in the areas that have low income. Although in Prince George, interestingly, in Prince George's County, which is considered to be the richest Black county in Maryland, and some individuals in possibly in the United States, but there are still food deserts. within Prince George's County, and different explanation. And we also said that what separates the rich and the poor in terms of health could also be the absence of green spaces. They have more green spaces in the rich counties and less green spaces in the poor counties. And then what could also mediate is that the high stress levels, because we know that even among rich families, they do suffer from high stress levels, and anxiety, which are driven by racial discrimination and also the very essence of living in highly structured racist communities. Those are that's one of the great dividers, in that both the rich and the poor tend to suffer from discrimination. And so in conclusion, I would say that we have three things going on. Then the rich and the poor both do have the challenges when it comes to optimum health, but more on the side of rich because of the affordability of insurance, the affordability of opportunities to get better food items, even though they might be living in a food desert, they can always travel and go to other communities and purchase food. And transportation might not be the big problem of the rich, but it might be the big problem of the poor. I'm sure that towards the end, we would have an opportunity to make some suggestions, but I just wanted to lay out a framework that said that, yes, there are intersectionalities in both Baltimore and within Maryland and across the Mid-Atlantic region, where we see evidence of differences in health outcomes between the rich and the poor, whether you look at rich counties and poor counties, or rich states within the Atlantic region, or families within, let's say, for example, Maryland. And then we look at some of the health conditions, whether they're chronic disease or infectious disease. And we're now caught up with the big infectious disease, which supports the notion of intersectionality, but more so on the side of poor communities having a greater burden of infectious disease and also chronic disease. Thank you.
Thank you so much for answering a question, helping us to understand the connection or intersectionality between health inequities and or health outcomes and wealth inequities. Thank you also for giving us just the framework for this and some kind of framework for the data that we will see throughout this presentation. So thank you so much. At this time, I'm going to ask Dr. Nesbitt, given what the data is revealing, are the COVID-19 outcomes in your respective communities impacted by health disparities, and what resources or approaches are you using to aid those who are not adequately insured? So I thank you and invite you at this time to share your presentation.
Oh, I'm just talking. I'm over here just talking. I hadn't unmuted, so my apologies. I was saying that I think I'm going to go ahead and pivot, given that we've had such a robust framework and setting by Dr. Braithwaite, and just give you just in a couple of seconds a higher level setting of what we're seeing in the district. We're close to 15,000 cases in the district. If you go to the next slide, you'll be able to see it there, where we had our greatest impact in April. Things have calmed down a bit, but of course they're not where we want them to be because we're still having a loss of life. You'll see that like in many jurisdictions, the groups that are mostly impacted are people in the age groups between 21 and 40 on the next slide. but the rates are higher amongst our older people because they are a smaller proportion of our population. Unfortunately, on the next slide, you will also begin to see that brown and black folks, the Latinx population, and African Americans and blacks are disproportionately impacted. That's where we see our greatest number of cases, and the death rates are higher in those groups as well. And so what we've had to do is we had to be very strategic in terms of how we were allocating resources. And that allocation of resources began very early in our response. And a couple of examples, in the District of Columbia, we have the second highest insurance rate of any state. We go ahead and call ourselves a state for the purposes of things like insurance. And we have one of the highest per capita or per population rates of primary care doctors per individual of any jurisdiction. But we still knew that we were going to have challenges with people being able to access things like testing very early on as that conversation was moving across the country. And just like any other jurisdiction that was setting up options for people to get tested, we wanted to ensure that any public response for testing went into those communities that was already beginning to have a disproportionate burden of disease, given that whether or not that burden of disease was because they were in those frontline jobs, being the people who were still going to work in our grocery stores or on the front lines in our healthcare system. When people hear that, they think about doctors and nurses, but a lot of being on the front lines in our healthcare system are because they work in environmental services, or they're the people at the front desk in our hospitals and healthcare facilities. So our first public mass testing sites were in our low-income communities. So those sites that the city funded, we put those in our communities where healthcare access in terms of hospitals, urgent care centers were the least dense in our community. So putting those public funded assets there and then growing them out across the rest of the city. Other things that we did is that we invested and we funded places for people to be able to isolate and quarantine. And all of these things are regardless of whether or not you have insurance, regardless of whether or not you are employed. If you are diagnosed with COVID or you've been in close contact with someone who has COVID, the district will provide you a place to stay during the time that you need to be in isolation or quarantine. And we make sure people understand that this is a different concept or a different housing environment than when people think about usually being sheltered by the city. And this is because we know that people who live in apartments where they're specifically sharing a bathroom with the rest of their family members, that's one of the challenges that we've had in decreasing the risk of spread amongst family members. And this is more common among families and communities of color. Along with that, we know that some folks who are hourly wage earners may go and continue to work after they've had an exposure because they don't have the ability to still provide themselves with basic needs. So food, basic household items. And so while they are in quarantine, we provide that food. We provide them with the household goods that they need during that quarantine period of time to reduce the likelihood that they will still be going out to work and trying to secure those goods for their household. So those are just some examples of the things that we have been doing to help decrease transmission in communities of color. What I like for people to think about, and as we get into the Q&A discussion, just seeding this for discussion, because a lot of the focus is on disparities and inequities that have happened in COVID outcomes. They are not a function of the acute nature of the emerging infectious disease or something unique to COVID-19 itself. And I think Dr. Braithwaite talked about this. They are part of the systemic things that lead to inequities, right? So when we talk about people who are being most at risk, it's a function of their educational opportunities that they've had over the course of their life that have caused them to have the type of jobs that they've had. It's a function of their housing options that they've had throughout their life that have led them to live under the conditions that they live in, within more densely populated neighborhoods, with the average mean number of individuals per household living in intergenerational households, not often of their own choosing. So those are the types of things that we really have to be mindful of when we're talking about eliminating inequities in COVID-19 outcomes. The conversation should be elevated to how we eliminate inequities in outcomes, health outcomes, period, and looking at both short-term and long-term solutions for that. So I'll end there. Thank you.
Excellent. Thank you so much. Thank you for helping us also to unpack the disparities that we personally experienced in our congregations, and of course, I'm sure many of you have in your context as related to persons who are Black, Indigenous people of color and across the spectrum. Thank you so much, Dr. Nesbitt, Dr. Braithwaite. I invite Dr. Jaraza to please lead us with her presentation.
Now, are you guys able to see my screen okay? Yes.
Yes,
I think I saw someone nod. All right. Well, thank you guys again for the opportunity to speak. You know, both Dr. Nesbitt as well as Dr. Braithwaite covered a lot of this, so I'm going to go through pretty quickly. At a high level, just our data, we just surpassed 15,000 cases. And you can see that Baltimore City experienced a peak in cases towards the end of May. We subsequently saw improvement in our average count per day, and then experienced another peak in the latter part of July, which was about a month after reopening. We implemented a number of restrictive measures following that, and we've since seen a decline. And so we're now averaging around 44 new cases per day in our 7-day average. However, as Dr. Nesbitt noted, when you look at some of the differences, specifically where race and ethnicity are known, we see significant disparities where African Americans account for the majority of cases where race is known. And Baltimore City is about 60% African American per the most recent census, yet account for close to 70% of cases. Likewise, when we look at our Latinx population, they too have experienced a significantly high positivity rate, specifically when you're looking at cases where ethnicity is known, where they have about 21% positivity for those that have been tested. And in Baltimore City, Latinx makes up about 5% of our population. Likewise, looking across different zip codes in the city, we see disparities between 21215, which is more close to 80% African American, and then 21224 houses a large number of our Latinx population. So going very briefly into the social determinants of health, because Dr. Nesbitt did cover it, what we know is that African Americans and minorities in general are more likely to live in crowded living situations, more likely to be in multi-generational household. We've experienced this firsthand with our Latinx community in particular. They have jobs where they have to continue to work. They may not have paid or sick leave. They're less likely to have an opportunity where they can telework. And all of these things are contributing to increasing their risk of exposure, specifically taking more public transportation. And then there's also just medical mistrust. So we know that there is a distrust and there's a disconnect sometimes from the medical community, even though similar to DC, we have a pretty highly insured rate, and we have world-class health institutions. So this chart is actually taken directly from the CDC. And again, we've seen something very similar in our data, where there are higher rates of hospitalization, as well as higher case rate ratios in African Americans in our Latinx community. The same goes for deaths. Let's get through that. So very similar to DC, Baltimore set up a triage respite and isolation center at a Lord Baltimore hotel. So this is intended to be a safe place where residents who are positive or are awaiting results can come and be safely housed. You have access to washing machine, you have your meals delivered, and there's also clinical support staff as well as care coordination on site. We're bilingual there, so we're able to serve our Latinx community. And again, this is intended for anyone, regardless of insurance status, to be able to come and safely isolate or quarantine. And again, this is a city-supported service, along with the University of Maryland Medical System, that does provide some of the clinical support. We also started mobile testing back in May, after we set up our initial stationary testing site in April. When we began our mobile testing, our focus was on communities that we knew would have very little to no access to testing. So specifically those that might have just low access to healthcare in general. So we focused on South Baltimore. We also focused on 21224, again, an area where a lot of our Latinx community is located. We were early on seeing high positivity amongst this group, and so formed partnerships with community-based organizations in those parts of the city to begin mobile testing. And early on would have lines around the block for people to come in and get access to free testing. We've continued that testing as well. Now we're looking across the city to understand, are there other parts with significant disparities where we have partners that we can work with to bring in the community. These are walk-up testing only. Individuals don't require a car and they don't require an appointment. So for additional resources or to learn more about what we're doing, you can certainly go to our website, Maryland Department of Health, or CDC.
Thank you so much. Thank you. And we will make these slides available to all who've registered for this presentation. Also want to just give thanks again for Dr. Jaraza for that presentation, for Dr. Nesbitt and Dr. Braithwaite. At this time, I'm going to move the conversation over to talk about the policies and practices, how they come together on the front lines of the battle for wellness. Dr. Interior, your work has focused on minority communities. What has your experience been with the cancer program and the current pandemic? What changes are needed to improve health outcomes of the populations you serve?
Sure, I'm going to try to share my screen. Are you guys able to see me? Thumbs up, okay. All right, let's see. So thank you again for the invitation. It's an honor to be here with you guys. Going to take it kind of in a slightly different direction and talk from a cancer framework where from my program, I don't actually have that much data, but going to give a little context and I think bring it into some of the early speakers from a cancer perspective as far as health equity goes. So just a couple of background slides on cancer in African Americans. In 2019, there was an estimated over 200,000 new cases of cancer in both African American men and women, which translated into over 73,000 cancer deaths. Four most common forms of cancer found in African American men and women are lung, breast, prostate, and colorectal cancer. And it's important to note that those are 4 cancers that we can screen for, which means that we have the ability to detect these cancers earlier on. Early detection leads to improved outcomes in terms of survivability and also quality of life after a diagnosis of cancer. Cancer is the second leading cause of death for African Americans right after heart disease, so definitely up there. But I think oftentimes when we talk about cancer, people feel like it is a death sentence. It's a conversation that people don't want to have, they don't want to initiate. So it's also important to note that we've made a lot of strides in terms of survivability after a diagnosis of cancer. And as of 2019, there were almost 17 million people who were living and living well after a diagnosis of cancer. A lot of health inequities as far as cancer. These are a couple of examples. If you look at African American men and the risk of mortality from prostate cancer in comparison to their white counterparts, it's 111% increased risk, which is pretty phenomenal numbers. New cases of breast cancer are diagnosed more often in African American women who are under the age of 45. So typically, breast cancer is more common in white women. However, when you look at women who are younger, which we expect to see increased cancer as women get older, but in younger women, African American women are more likely to be diagnosed and to have more aggressive forms of cancer. Overall, African American women have about a 39% increased higher risk of dying from breast cancer when compared to their counterparts. And if we looked at things like colorectal cancer, which impact both men and women, African Americans have the highest rates compared to any other racial or ethnic group. So this slide really reflects on the previous presenters' conversations. What are the reasons? When we look at these disparities, why do we see these disparities? What are the causes? And so we've talked about things like access to healthcare. What is your baseline physical and mental health? Obviously, if you go in, the healthier you are, the more likely you're to have a positive outcomes. What are treatments received? What's your socioeconomic status? What's your genetics or your family history? And what potential environmental exposures do you have? What is your lifestyle? The right-hand column really looks at things where there are modifiable risk factors, so things that we can do better. And in fact, if you look, up to 42% of cancers are thought to be preventable through lifestyle modification, which I think is really important. So looking at diet, weight, consumption of tobacco, alcohol, physical activity, or the flip side, physical inactivity, and then cultural beliefs. What do we believe about cancer in terms of there are a lot of folks who kind of have the mentality that if I don't acknowledge it, it's not there. And by the time they're ready to acknowledge it, it's too late and we're in a place where we can't go. Clinical trials participation. I think there have been a lot of conversations in recent weeks and months about clinical trial participation around the COVID-19 vaccine, right? And if we don't participate in those trials, that means that the data isn't reflective of us. So when we get information, there are policies that are developed, but they're not informed by our data, even though we might be the people who are most impacted by the disease states such as cancer that are impacted. And then health literacy too. I think 2020 has been phenomenal for a lot of things, but one of the things that we really have to look at, given our current political climate, is information, whether that be misinformation or disinformation. So are you literate? And depending on your health literacy, where do you get your information? How do you understand that? So pulling that all together to cancer and COVID-19, in Maryland to date, over 37,000 people have died from COVID-19 versus the comparison of an estimated 11,000 people who will die this year from cancer. So I think the reality is we have to be starkly aware of COVID-19. We have to be very aware of the impact it will have, but that doesn't mean we can set aside all of the other things. You can say cancer, but insert diabetes, high blood pressure, high cholesterol, obesity. All of those things can't be set aside in the context of COVID-19. Looking at data from 23 states, they found that there was a drop in cancer screening. So thinking about mammograms, pap smears, colonoscopies of 85%. 85% drop in cancer screenings because of COVID-19. Obviously, doctors' offices closed their doors because we wanted to make sure that we were giving access to care for treatment of COVID-19, which I think is really important. But there are estimates that show that we expect to see increases of up to 10,000 deaths from just colorectal and breast cancer alone over the next decade. And I'm definitely very worried that a lot of that burden is going to fall in populations of color, right? Because we already have those disparities. And so those gaps are potentially going to be widened. For the cancer program, we did stop for a period of time offering screenings, but even when we reopened the program to do screenings, people have other needs. Like you're saying, if people need to go to work, they can't be worried about missing another day of work to go get a mammogram or a colonoscopy when they possibly had to be quarantining because of family members. And for the populations that are served by our program, which are primarily Black and Brown people, so African Americans and members of the Latinx community, they've had a lot of death and dying. So people are actually scared too. They don't necessarily want to be out and about in the community. But with all of these things, I still think it's important that we go to a positive message, which is number one, people being informed in terms of knowing what their individual risks are for cancer and making sure that they are plugged in with a primary care physician. We talked about the fact that we are blessed in the sense that we're in areas where people have insurance, they have access to top tier healthcare. And so making sure that people actually utilize that healthcare and get the best that they can. I think it's important that people be encouraged that with all that is going on, again, with early detection as it relates to cancer and with our increasing knowledge around COVID, we can do better and we must do better. And it's really important that I think people be empowered to take action, whereas people have kind of set a lot of their healthcare to the side because they don't want to come in or they're scared. People need to make sure that they're plugging into healthcare, not walking away because the disparities that exist. Like we said, we talked about, Dr. Nesbitt made mention to the fact that systemic barriers have been in place and COVID-19 is not the cause of these, it's just overexposing these. And if we're not mindful, 10 years from now, we're gonna look back and say, my God, we were even worse off than we were when this all started. So just a reminder to us all that together with all of this information, I think we certainly can make a difference, but action is important. These are a couple of resources, and with that, I will close.
Excellent. Thank you, Dr. Interior. So many questions I have for you, and I'll come back later to ask them. In an effort to remain on track, I want to invite Mr. Stoner to share with us. He is the director of the Washington County Public Health Department, Washington County Department of Health. And so I'd like him to come and give his presentation at this time.
Sure. Thank you for the invitation. I'll just be brief because of a lot of what we're seeing here, in particular with COVID-19 and health disparities, is what a lot of the other presenters have already spoken about. But just to give a little bit more rural lens to it, it may be rural, but again, we're seeing the very same things that everyone else has been speaking about. We're a population of about 151,000, predominantly white. Our Black population is about 12.5%. Asian population is just under 2%. And from an ethnicity standpoint, our Latinx population, or individuals that identify with that, is just under 6%. From a COVID perspective, we're rural, so we don't see as many cases as some of the other presenters. We've had currently about 1,644 cases, about 150 hospitalizations, and unfortunately 36 deaths. Our gender distribution is about 50-50, and it's been about that throughout the whole pandemic thus far. If you really look at from a case perspective, our predominant age groups for cases are the 20 to 29, 30 to 39, and 50 to 59. Although, now that's total since pandemic has started. Although our top growers, as far as cases are concerned, is I'm sure what everyone else is seeing, the younger populations are really fueling what we're seeing, especially over the past month. If you look at hospitalizations, no major surprise with that. Our 80 and up, 60 to 69, and 70 to 79 populations are the biggest ones as far as hospitalizations. And then deaths, again, our 80 and up, 60 to 69, and our 70 to 79. Really looking at health disparities, as I mentioned, our Latinx population is about 5.9% here, but from a case perspective, it represents about 15% of our total cases. From a hospitalization perspective, our Black population is about 12.5%, but when you look at hospitalizations, that population makes up about 20% of the hospitalizations that we've seen. And then surprisingly, our deaths have been pretty even with the representative or respective population distribution. That's been a surprise to us. From a challenge perspective, again, not really unlike the other presenters, what they have seen, key barriers that we identified early on were access to care, mainly transportation. We're very spread out county. It can take you from the city center close to half an hour to get to South County and West County. So transportation just across the board, regardless of whatever the issue is, has always been historically an issue for us. Resources, especially when you're talking about PPE and education, a lot of our underserved communities, especially our communities of color, don't have the resources to acquire appropriate PPE. And then the other big challenge that we found, and this was mentioned by a couple of the other presenters, is the issue of multi-generational housing, especially as it comes to isolation and also with PPE. Our strategy was really adopted utilizing the CDC COVID-19 response health equity strategy, and in particular, priority number 2, which really focuses on expanding programs and practices revolving around testing, contact tracing, isolation, linkage to healthcare, and then recovery, especially from some of the unintended consequences that have arisen. We have always had very strong partnerships with our community and faith-based organizations, and obviously they were the first individuals that we contacted in really tackling this issue, really focusing on building capacity to reach those disproportionately impacted populations, and in particular the populations of color. develop effective and culturally responsive and sensitive communications, which we really felt was important. Developed strategies to increase resources in those areas, and then really focusing now, we've started to focus on building capacity from a communication perspective and also from a site perspective for the upcoming vaccination administration. So some of our key actions that we undertook in reaching out to those vulnerable populations was again, as we've heard, mobile testing, free neighborhood-based testing, walk up, no appointments necessary. Also transportation through some of the federal CARES Act money that came down to us. We set aside a pot of money for transportation for individuals who may need to go to treatment, who may need to go to their healthcare provider, who maybe need to go to a mobile testing clinic or our major test clinic that's happening at their community hospital. Education and awareness was a biggie. Just because the education and awareness materials are out there doesn't necessarily mean people are motivated or have the attitudes to engage. So we've done a lot of door-to-door networking. We've tapped into our faith-based community and a lot of the established groups that they have. We have used our peer recovery specialist from our harm reduction program related to opiates and their established networks with community partners, and in particular with those individuals who are homeless and may need to seek care. Again, with isolation and teaching and giving the understanding and awareness of, if you test positive, this is what isolation means. And if you choose to stay at home, because we also had a program where we had a contract with a local hotel to house individuals if they didn't have the resources or if they chose to isolate away from their families. But for those individuals, and in particular, individuals of color who are from those multi-generational families and housed in the same house, we found that particularly challenging because not a lot of those individuals chose to isolate by themselves at a hotel. And then, of course, as I mentioned, really looking at building that capacity for vaccinations. Again, nothing new to Washington County, but a lot of hesitancy within communities of color, in particular around testing and also with vaccination. We also focused a lot on referral to care and linking individuals to our federally qualified health center here. I think someone brought it up previously. It may have been Dr. Nesbitt. I can't remember who it was, but the concept of individuals just across all races not seeking routine care and sort of setting those issues aside. We found it particularly burdensome for our diabetics and a lot of diabetic emergencies and a lot of issues related to those individuals. Contact tracing was another biggie. We are in the process, haven't been able to get there yet, but we're in the process of trying to secure bilingual hiring of some contact tracers. And then also just in general linkage to services, because as has been stated again before, a lot of the individuals that are of color here in Washington County work in service-oriented positions, food industries. Lots of individuals, unfortunately, here during our lockdowns, lost jobs or were unable to pay bills. So we tried to go beyond that healthcare linkage and really provide resources to individuals through our Department of Social Services, through our economic development and our division of our county government, and also through our Community Action Council for, we're moving into heating season, but throughout the summer, it was really like utilities, making sure that their utilities were able to be paid and they didn't get their lights turned out. So in a nutshell, that's where we are, where we've been, and what we're continuing to do. But I would stress at this point, we obviously are continuing to try to combat and limit the spread, but we're really trying to ramp up on the vaccination end of it. really getting a lot of awareness out there, education out there, because we've seen a lot of hesitancy just across the board, but again, in particular, in our communities of color.
Excellent. Thank you so much. You all have mentioned so many important pieces of information for us tonight in ways that congregations have been involved and perhaps can be. I know in Dr. Nesbitt's presentation and Dr. Jaraz's presentation, you shared how congregations have come together to serve as mobile sites. You've also shared ways that persons can help others get to places so that they can have the testing and treatment needed. We talked about ways that perhaps persons can participate in contact tracing. Bilingual contact tracers are needed. You've mentioned the vaccination piece of all of this, and I'm wondering a little bit about how persons of color have participated or will participate in the vaccination process, or better yet, what's the best way of saying it? The exploratory research that will happen around vaccinations. You've talked about ways that the clinical trials have or will occur, and some of the triage centers that are available where you are. I'm just wondering about any other ways that you'd like to share with us in the last few minutes that we have together, that some concrete ways that congregations can participate in this, in the work that is before us of recovery and restitution. And also want to ask those who are on the line, please make sure you put your questions, because it's that time that we would love to hear questions. I see quite a few folks from physicians and faith-based leaders, parish nurses on the line and others. So I just want to invite you to please ask your questions while we have these gifted individuals with us here tonight. And again, thank you. Any last comments you want to share with us while we're waiting for the questions to be posted?
I think that one of the things that we should mention in terms of what churches can do, we know that stress and anxiety in the area of mental health counseling have been a bit neglected. And so the spiritual care, the spiritual comfort that churches can provide to individuals who are recovering, individuals, families that are suffering, I think that element of healing is greatly needed, but is something that I think overall the state has not yet come to grips with, the element of mental health within the context of COVID-19. And I think that's a big role that the churches can play in terms of providing counseling and comfort to those who are hurting, to those who are suffering.
Yeah, I absolutely would echo that. You know, about a few months ago, it's been now, I actually reached out. I have a good friend who is the presiding bishop over the Full Gospel Church, and we had a conversation, as many churches were really dealing with the virtual worship experience, and how I could communicate around that particular principle, and really dealing with the notion that, you know, the church is the people and not the actual building, and how you still provide that you know, sort of pastoral care and dealing with the emotional and mental toll that happens is actually, you know, we're trained to think about it as adjustment disorder that people develop. And some of us have launched programs and initiatives. We even have one in the district that's very focused on helping families deal with the virtual learning experience that they are having. And so as many who are able to work with individuals and families in that space, and recognizing that it does not have to be restricted to those who have a COVID-19 diagnosis, but also with individuals who are just coping with a different life experience right now, because we've asked people to do things very differently. I wanted to not miss the opportunity to elevate some of the things that Dr. Ntiri referenced in her presentation. We have really been experiencing people being reluctant to engage with the healthcare system because of their fear or anxiety about being exposed to COVID-19. And from the roles that many of us have, we've worked very hard to ensure that healthcare environments are safe, and that the risk of being exposed to COVID-19 patients when you go into your doctor's office for your preventive health services, to get your flu shot, all of those things that we're asking you to do to stay well and to make sure that something isn't brewing underneath. So helping to make sure that those messages come across. We talk about them as being, we don't want an epidemic in the middle of a pandemic. And what that means is that we can't have a surge in cancer cases in the Black community, or more people dying from heart attacks because they're staying at home and not calling 911 to get the help that they need. So I think elevating those types of messages cannot be understated. We do want more people of color to participate in clinical trials for the SARS-CoV-2 vaccine that prevents COVID-19, but we have a flu vaccine right now, right? So how do we elevate messages to really make sure that communities of color, who are always the lowest group in getting the flu vaccine, get out there and get that vaccine this year, so that you don't end up in hospitals with influenza this year, and you can be at home safe with your families. So really helping to make sure, I don't think we can understate that message enough, to make sure that we stay engaged with our doctors, that we're taking care of both our mental and emotional wellness and our physical wellness, getting all of the preventive care that is still there in the health system to be provided for you.
Yeah, and I think I'll just add on to that. I mean, anecdotally, I'll tell you the worst story that I've heard in terms of a person trying to avoid the hospital was from one of our residents, one of our doctors in training, who took care of a patient in the hospital who was having strokes at home and was clearly demonstrating signs of stroke and did not want to go to the hospital. And by the time she presented, her arms and legs wouldn't move. You know, so this is real. It's not fake. It's happening. And I think too, medicine has expounded. I mean, today I saw patients in person. I talked to patients on the phone. I did video visits. My oldest patient that I do video visits with is 90 years old. So when folks are like, I can't do this, I'm like, yeah, you can, we can. And so reminding folks too that engaging with the healthcare system, for those who are like, I'm not coming in, that's fine. We're mindful of how many touch points you need to have with the health system. Okay, you don't want to come in to see me, we'll do a video visit. You've got a blood pressure cuff at home, but I need you to go to the lab to get your labs. Fine, you don't want to come into the office to get to the flu shot, go to Walmart or Target near your house, it doesn't matter. But it's really, really important, because I think the one thing that we've all talked about is the systemic level of disparities. And there's a great fear that the disparities are going to be compounded exponentially. And it's going to be populations of colors that are hit. And I think the church, as a trusted voice in the community, has such a unique opportunity to address this, just by saying, guys, make sure you're staying engaged, make sure that you don't lose sight of your doctor. If you don't want to go in, make sure you're calling, those types of things. I think the church is extremely powerful in that way. And that would probably be the one takeaway, is just making sure that the church is a trusted source of information.
One of the things that I would want to introduce is that, in terms of distrust and of the medical system, is an interesting thing within the people of color, in that Black adults have less positive views of medical scientists than Hispanics and whites. So when we look at people of color, we can't just say, well, this is the situation, but we have to look within that to indicate that the Hispanics are more trustful of the medical science than Blacks are, and that African Americans are more skeptical of experimental treatment and potential COVID-19 vaccine than Hispanics and whites are. So we have now to really position our message to the extent that we know that when we appeal to Blacks, this is one message. When we appeal to Hispanics and Latinx, this is another message. And that would help frame, I think, that would help frame the impact that we want to have by differentiating message between Blacks and Hispanics.
Thank you, Dr. Braithwaite. Just the whole conversation around differentiation in the conversation, the complexities of it, how, just like with Katrina, all of the disparities that were there before Katrina were definitely thereafter and exacerbated, and the same with COVID-19. Thank you, Dr. Interior, for helping us to understand, again, the importance of maintaining our health even during this pandemic so that, as Dr. Nesbitt said, we do not reach an epidemic of other proportions and other healthcare issues. The information that's been shared here is just invaluable. The time that you've spent with us, we just can't thank you all enough. There's one question, I'm going to try to make sure we have a hard stop at 8:10 that came in. Let's see here. It is, has there been research on the disparities of the homeless and those with mental illnesses? It's a question that came in.
So I can go ahead and I'll start with that. I wouldn't call it research, but our surveillance data does monitor how individuals who live in congregate shelter have been impacted compared to other populations. And similar to many other jurisdictions, individuals who are unsheltered, so living in, or individuals experiencing homelessness who live in congregate shelter, we did see some cases in that population, but we're able to rapidly respond to them. We've made a very conscious decision to have individuals who were experiencing homelessness, living in congregate shelter, who were over the age of 65 or who had chronic health conditions. We moved them out of that environment very early in our pandemic to decrease the risk of severe illness for them if they were to be exposed or death. So we believe some of the outcomes that we experienced that were not as severe as they could have been were because of decisions like that. But congregate settings overall are very difficult because individuals are in close proximity to one another. They share rooms, share bathrooms, bathing facilities, all of those types of things. And so the risk of transmission is increased. But again, this goes back to what are the root causes of those inequities. And again, these are individuals who have challenges with long-term housing and address the issues that lead to them to be unstably housed in the beginning, then we can avoid the challenges related to their housing status. We did not see some of the same challenges in individuals who have a behavioral health diagnosis who were not living in a congregate setting.
From our perspective, one of the things that we have studied is the whole concept of eviction, not just a concept, but the reality of home eviction. And the data indicate that individuals who are facing home eviction during COVID even suffer highest levels of stress and anxiety. And that we're trying to help them. That's why we're funding utilities and rent assistance so that individuals do not become homeless. Eviction should not take place during COVID-19 because that is a relationship between housing and healthcare. Housing is healthcare. And if individuals are evicted during the pandemic, then we know that it worsens the spread of COVID-19. So there are studies that indicate that eviction is a threat to public health, is a threat to COVID-19, and we try to prevent evictions.
Thank you. Eviction is a threat to public health. Racism is a threat to public health. Stress is a threat to public health. We have our work to do, and we know that our faith is grounded in the fact that we are to love our neighbors as we love ourselves, and to definitely love God, and to do all that we can to make sure that each person has the basic human rights they deserve. And so with that said, tonight, it is almost 8:10. I think we've answered all the questions that we've received. Again, want to ask the co-moderators if they have any last words that they'd like to share before we end tonight. If not, everybody.
We said all these are a threat to public health, but religion is the balm in Gilead.
Amen to that. Amen to that. Amen to that. So,
I will add for people to look forward for action plans for the churches to do. So all of these are systemic issues. So what are we do? So look for the plans from us of what you can do to help make sure these things are not going on forever.
yeah. And our social principles and as related to them in the United Methodist Church, and we'll make sure that you have all of that information. It is 8:10 tonight. Beloved, thank you for joining us and being a part of this discussion. Thank you for the ways in which you've offered your voice so that we can experience the change we seek. And thank you for being a person who is about helping other people tonight. God bless you. Thanks again for joining us. And we do hope to be in touch again soon. Thank you all.